screen, take a few minutes to read that, or like literally a minute to read it. Not the 4 bullet points underneath, but just that first bullet point. Okay, I've read the whole thing, so I know y'all are done. All right, so what risk factors does Ms. Jones have for colon cancer? Because you might have a question like this on your exam, and you have to be able to look at a case and let me know what the risk factors for colorectal cancer are. Because as a nurse, once you can identify those risk factors for colorectal cancer, our job is to educate or recommend screening. So our job is to offer primary prevention, secondary prevention, tertiary prevention, based on what we find. So what are the risk factors in this case? Yes, Sarah, right? Yes. Okay, Sarah. You didn't want it. Yes, tobacco use, absolutely. So Sarah, does it matter if she smoked, if she had a 10-year history or 30, does it matter? No. It does not. No, it's smoking. Over time, the 5-year history is going to increase. So, no, it doesn't matter. If she smokes, increases the risk of colorectal cancer. The more she smokes, the more it increases the risk. But the smoking itself is the risk factor for colorectal cancer. One more, probably. Her age. Tell me about her age. She's 60. She's 60. Yeah, she is. Tell me about that. I'm sorry. I don't see you on that.
50 years old.
Say that again, Carly.
50 years old is the contact.
Okay, so you said at age 50, people are more likely to be diagnosed with colorectal cancer. Did you say that?
Yeah.
Okay, so at an age of 60 is going to increase the risk of colorectal cancer. As people age, it increases the risk of colorectal cancer. That's why colonoscopy started, or they start at age 50, because we know the risk increases starting at age 50. I showed y'all last week, this Preventive Services Task Force, we can actually start at 45, because why wait to 50? Why wait? We know people are they're being diagnosed at 50, let's start screening them earlier at age 45, okay? Give me another one. Emily.
She has a first degree relative as a history of.
Yep, first degree relative with a history of colorectal cancer, absolutely. Is that all of them?
No.
Nope, there's another one? What is it, Danielle? Did you say that wasn't all? You didn't? Okay. It sounded like it. Are there any other risk factors for colorectal cancer?
You exercise, the lack thereof.
You said the lack thereof?
Yeah.
Your classmates disagree.
I read it as a year, that's on these.
Oh, you're talking about the wine. Oh, okay, yeah. So she's getting 150 minutes of walking throughout the week. Your classmate said, that's enough miles. What are you trying to do? She's 60 years old. Molly's like, I run more than 150 minutes a week. She's got to up her game here. So we've only identified 3 risk factors here: age, smoking, and first degree relative. So which one? Do you have something else?
You just said the first degree relative.
Oh, okay. Oh, yeah, Emily said that. Okay, so when we think about modifiable risk factors, hold on, that's what you need. Modifiable risk factors, those are risk factors that the patient can actually modify. Out of those 3, which risk factors can be modified? Smoking. She can't do anything about her age. She can't do anything about that first degree relative. Okay, now we're going to tell her, as you age, it increases the risk of colon cancer. The first degree relative increases the risk for colon cancer. So it's just something for patients to be mindful of. But the only thing that she can really change is the smoking. So just make sure y'all understand the difference between modifiable risk factors and non-modifiable. When we educate, we're going to be focusing on the modifiable stuff. We can't do anything about somebody's race, somebody's age, somebody's first degree relative. Okay? So you will see modifiable, non-modifiable in your next exam. In your textbook, it'll have a big M, a capital M, beside things that are modifiable. real key. Molly wants her to work out more, you're going to give her the pace intended to go. So yeah, that's hypertension. DM2 stands for type 2 diabetes. So somebody can have type 2 diabetes, but have very well controlled diabetes. Okay? And then COPD stands for chronic obstructive pulmonary disease. Thanks for bringing that to my attention. Okay, what else was I going to add? Oh, what are the things that she's doing well?
She walking.
I heard walking. Okay, is that enough? That's enough. Molly, 150 minutes, that's enough. What about the wine? What y'all think about that?
That's good.
That's good, right? Celebrate your birthday, lady. Yes, it says excessive alcohol usage is going to increase the risk. That is not excessive at all. All right, what is the correct order for the assessment techniques of the abdomen and why? That is, I can't see your face. Tremaya, you moved up. Yeah, so Tremaya, what are the assessment techniques, the order, and why is that order that way?
You can inspect, auscultate, and palpate,
Yes, why is auscultation before palpation?
because you don't want to disrupt any fluid in the bowels, just in
Okay.
case it's a mass or anything like that.
Well, not just fluid, but you just don't wanna cause any type of disruption by going in there and palpating. So we inspect, we auscultate, and then we palpate. Excellent. That's what it's my screen. Okay, what is the difference between a pot belly and generalized abdominal distension in a child? Why have you missed this on the last quiz? There was some confusion about this. Yes.
Well, potbelly is normal because most intestines are kind of bigger when they're pregnant, and, abdominal extension is abnormal. And good issue.
Okay, did y'all hear on this side of the room? Yeah, okay. So when you look at a kid and you see a round apple, what can kind of clue you into this is a pot belly or generalized abdominal distension? Not you. Oh, I like this. So pot belly is usually soft to palpation, but what about just inspection? Because you're right, if you touch a pot belly, it's nice and soft. Okay, so Nadia said if the patient has pot belly, it doesn't look very taut or tight. Taut as in T-A-U, taut. Right? Yeah, if there's significant amount of distension, think about all that skin that's pulling down, the skin is actually thinning here, because it's pulling down, so you can see the rib cage. Anything else you might see? Stretch marks? Yep. Anything else? You're definitely not gonna see stretch marks with private, right? Anything else?
Maybe just like out of proportion, like there's a certain proportion that all kids have.
Yeah, even with the pocket.
Yeah.
So what's going on, what do you think about this proportion?
Distinction.
These abdominal distension, so tell me about it. What, when you look at this, why does this look abnormal? So the circumference, it doesn't like protrude down like pot belly. Anything else? Yes?
I was about to say I think it's called umbilical hernia, because I had one, and I always say I had to get cut off. I had an alley and they made it an E.
Okay. So, yeah, it may not be an umbilical hernia though.
I think that's what they call mine, that's why I just said it.
Gotcha. So this is the umbilicus or the umbilicus or the belly. And the reason it looks protruded and almost like enlarged is because of this distended abdomen. If you think about kids with pot belly, their umbilicus doesn't look like this. It doesn't look swollen, it doesn't look protruded. Now, they may have an outlet, but it's not swollen, or it doesn't have that swollen appearance, okay? Many of you selected that generalized abdominal distension was a normal finding in kids on your quiz. Is there any reason, can y'all explain why y'all chose it? Yes, Kay.
So I was confused, I got it wrong, because I feel like in our lecture, we just talked about the fact that it was like distended or it could be, look round. So going off of that lecture, I was like, oh, distension it's fine, it makes sense. But there was, going back when I looked at the actual book and the reading, it says like, it's okay to be rounded, but then it's distension. So I think it's just the terms, because I think I was getting confused in the lecture. Distended was like, oh, it's just a round. So I was, yeah, it seemed similar in the lecture, so.
Got it. Everybody's like, yeah. Same thing? Everybody feel the same way?
I feel like I just read it quickly, was like, oh yeah, that's normal. I just,
Yeah.
that's the pot belly.
Yeah,
I
we
don't
just
see
talked
any
about it.
interchanges.
So y'all consider potbelly and distension to kind of.
Yeah.
Okay, but now you know that generalized abdominal distension is abnormal. Right? Okay, I'll give y'all points then. Okay, you're welcome. A lot of y'all missed. Something happened here. Something bad.
Like, in the lecture, you said that it would be after 6 or 7 years old, but
The potbelly.
yeah,
Right, that's true.
it would be abnormal after that.
Oh, yeah. Actually, the textbook says it can be abnormal at age 13, which I think is late in the game, but, yeah. So I'll give that back. Let me make a note to myself.
So I get a 90.
You're welcome.
Is that the last one?
2.
Which quiz was it the last one?
Yeah, it was the GI quiz.
I know, but what question?
Question 7.
Question 7.
Okay, so let's read this.
No,
these
no,
last two
9.
bullet points
9.
on the
Bad.
screen. So abdominal distension is normal in children, true or false? False, we got it. Abdominal distension is normal in older adults, true or false? False, 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 false. Abdominal distension is never normal, okay? A round belly is normal. A soft round belly, like Nadia was saying. Everybody doesn't have a flat six-pack like me. Everybody doesn't have a flat abdomen. So don't think flat is one thing that's normal. Round is normal too, okay? It's just that when that round belly becomes really round and it's tight and the skin is taut, and you can see those veins underneath the skin. And when you press it, it's really tight, feels like it's full of something, fluid or gas. Then we're talking about distension. Yes, can't see your face. Oh, that's Jason. Can I do what?
Can you hear me?
Oh, yeah, I can hear you.
So even if we got that right, can we just get a point blank period?
No. Absolutely not. You know that's not how that works, Jason. Kudos to you for getting it right. Yes.
I have a question too. So, have you ever heard of somebody having like a beer belly?
Yes.
So, would a beer belly be considered hot belly, or would they be more?
Oh, wait, that's a good
No.
question. That is.
That is a good question.
That is a good question. I guess you could call it pot belly in adults. Because the beer belly is still gonna be soft. It's not gonna be taut and tight like this. Yeah, sometimes they do look good and pregnant too. Yeah, but it's not tight. Okay. What makes it tight is that fluid that's in there that typically causes abdominal distension. All right, y'all. So let's get into the musculoskeletal system. Before we do that though,
Dr. Walker,
no, we'll talk about it at the end. Yes.
I got a question. Can you go over what like a hypoactive or hyperactive bowel sounds like?
Normal, active, hypoactive, hyperactive bowel sounds. Okay. So actually, who was that? I think Courtney's here, right? Courtney, are you here? No. Okay. So I took students to Tresvent last week. We're going to talk about that at the end of class. And Courtney was listening to her patient's lung sounds. And she was like, oh my gosh, I can hear all the bowel sounds. And so I listened to the lung sounds, and it was off the chain. It was a and the nurse looked at me, she saw my face, I was like, she said, yeah, he's having diarrhea right now. Makes sense. Okay, so when you're trying to differentiate between normal active and hyperactive bowel sounds, I was telling you all that it's really hard to explain. It takes more experience than anything. And so that's why Courtney was, when she heard that, she was like, wait a minute, this is abnormal, because I've been listening to my own bowel sounds, I've been listening to my family members' bowel sounds, and they're not this rapid, they're not this fast. So I'm not gonna give you any, I'm not gonna say on your exam, you can only hear bowel sounds every 2 to 3 seconds. Is that normal? I'm not giving you that, because your book doesn't even explain normoactive, hypoactive, and hyper in that way. So it's gonna take some time, some experience for you to be able to hear, oh, that's slower than usual, or that's faster than usual. So you're not gonna have any questions that ask you to differentiate between the two, if that helps you.
Okay,
It's actually hard for me to explain it too, it's just experience.
okay.
Okay, musculoskeletal, let's go. Is there any information from the patient's health history that will help us identify any effects on the musculoskeletal system? You know, we start this same way every time. Anything from the history? Yes? Oh, family history of arthritis at the very top, this. Hold on.
I was gonna say that.
No, I get you and you mixed up all the time. Let me see.
Oh, yeah, cause they named similar.
No, they're not.
Talking about Jalea and Aaliyah? They named similar.
That's Jalea.
But you said you got her mixed up with
This is
Aaliyah?
Destiny.
I ain't know you pointed.
Oh, no, I was talking about Destiny. I get y'all mixed up, because I remember you telling me about Destiny's Child. Then I feel like she said Destiny's Child one time, so I'm sorry if I call you Jalea. Okay, Jalea, were you about to say family history?
Yeah.
Okay, and you said family history. Anything else? Yes, Danita? Lifestyle like what? Smoking. Smoking comes up every single time. Smoking is going to increase the risk for musculoskeletal changes, specifically osteoporosis. Emily?
If they, exercise regularly, specifically strength.
Oh, wait, exercise.
Okay, you mean that will help promote? Oh, okay, gotcha. That's the good stuff that's happening. Yeah. Nadia? Okay. If they do work, Nadia said, if they do work where they're maybe putting a lot of strain and stress on their muscles, then they can increase their risk of injury, muscle and bone. Patricia?
Excessive alcohol.
Excessive alcohol intake, yeah. Katie?
If they're a woman,
If they're a woman, tell me about that.
based on all of the osteo, like arthritis and cirrhosis, they're all at higher risk. I think it's just because of the calcium strength in the bones.
Yep, you're absolutely right. Danita? Diet, tell me about that.
A lack of calcium and what they're inputting into their body and like.
Calcium, vitamin D. Rachel?
Do you play sports?
If they play any sports.
And do they protect themselves from
And if they protect themselves when they're playing sports, absolutely. So when a patient comes in, it never fails. Patient comes in with back pain, of course I'm going to use OCARS. When did it start? Can you point to it? Is it intermittent? Is it constant? How can you describe your pain for me? And I always ask, have you experienced any trauma or any injury lately? Like, have you been in a car accident? Have you been in any fights? Have you had any falls? Have you helped somebody move something? I always get a yes to that. Because my patients, tend to move a lot. Move from apartment to house, to homeless to house. They do a lot of movement. And so they're always moving stuff. Moving boxes, moving something. So have you moved recently? And they're like, oh yeah. I was helping my cousin move out of his apartment. I said, the pain happened around the time that happened, or maybe a few days after. They're like, yeah. So you spoilers. So always ask about trauma or injury, and then give your patient examples of what you mean by trauma and injury. Shamari?
Do you have the mic?
Oh, I do. Thank you. But y'all won't use the mic. All right, then, double standard here. All right, so, let's see, we cover everything we did. Okay, problem-based history. Patient comes in, well, y'all know how to do, y'all know how to assess pain, right? Yes, okay, we don't even have to go over that. Because in the chapter, like in the course schedule, it says that you need to know about musculoskeletal pain, and then you need to know about the impact on activities of daily living. So that's what we need to talk about. So what are ADLs or activities of daily living? What is that? Nadia, give me one. Okay, preparing your food. Mary? Getting dressed. Patricia? Eating. Destiny? Getting out of bed. You're absolutely right. Jalea?
Toileting?
Toileting, what does that mean? Cleaning the toilet?
No, going to the bathroom.
Going to the bathroom. Okay, Rachel. Bathing. Okay, let's look at our list here. Eating, mobility, so like getting around, transferring from a chair to a couch or from a chair to the bed, toileting, bathing, and getting dressed. So when a patient is having a musculoskeletal related issue, I want to know what impact is that having on their activities of daily living. Your textbook includes a few other ADLs, and that's how you'll hear them commonly referred to as ADLs, which stands for activities of daily living. Your textbook has a few, but when I found this image, this is the only one that had an image, and I like the image. So I want to know what impact does your musculoskeletal disorder have on your activities of daily living, and why do I want to know that, especially if it's an 87-year-old man who just broke his foot, he was painting his house, fell off his ladder, broke his foot. Why do I want to know how that ankle injury, foot injury, whatever is affecting his ADLs? Emily?
You wanna know how independent they are and if they need like assistance at home or if they need to get transferred to like a inpatient facility.
Right, absolutely. So you need to know what impact that injury is having on their ability to get dressed, to eat, to bathe, to be mobile, to go to the bathroom. So I had, and it doesn't just apply to musculoskeletal issues, it can apply to anything. I had a patient, she has used cocaine for as long as I've known her. And that's just kind of like part of her life. It does not affect her ability to do anything. She does whatever she wants to do. She works, she has grandchildren, you would never know that she uses cocaine. She's about, I'm gonna say she's about 200 pounds. And she's always had elevated blood pressure, like 200 over 114. Very high blood pressure, cocaine use, obese. I don't know her height, but definitely obese. And so she came in one day recently, probably, I'd say like in the past 3 months. She came in and she was probably 140 pounds. Her blood pressure was still extremely elevated. Her skin was really dry. Her mouth was really dry. It looked like she hadn't washed her face. And this is all like general inspection. I'm just looking at her like, what has happened to you? Something happened. So she had had a stroke about 6 months prior. And when I assessed her after having her stroke, I asked her about this, like, how has the stroke affected your ability to do these things? And it wasn't affecting her at the time. But she must have had another stroke in between the first time I saw her and the next time I saw her, because her ability just went absolutely down. And I was asking her, are you bathing yourself? She's like, I just don't have the strength to get up and go. I don't even have the strength to hold myself up in the shower or pull myself out of the tub. Are you feeding yourself? No, I don't really have she didn't have the means to feed herself, but she's like, I just don't have the strength to stand in the kitchen and cook. She's like, when I start cooking, I just get tired. I am exhausted. So her stroke was affecting her activities of daily living. And so I had to get her connected with a rehab facility, which she had an aunt that was willing to take her in And so now she lives with her aunt. She has regained all of her weight. I said, well, we could have kept some of that off, but she's regained some of her weight, and now she's back to like her baseline. And she's no longer using cocaine because she's living with her aunt, and she doesn't want anybody in the family to know that she uses cocaine. But, so I'm like, yes, I'm so glad you're not using cocaine anymore. But she was not able to care for herself. She wasn't able to do any of this stuff. And this affected her daily activity. So now she's getting rehab. Before she moved in with her aunt, she had a nurse coming in to help her do these things. And so we do have like home health nursing services. There are nurses that work in home health settings, meaning that nurses go to the patient's house and help them do some of these things. It might not be the nurse doing this, it might be more of like a medical assistant or a nursing aide doing this part, but nurses actually go into people's homes, check their blood pressures, help them with understanding their medicines and medication administration. And so when you see that somebody's injury, doesn't have to be musculoskeletal, it could be anything. When you see that it's affecting their activities of daily living, we gotta intervene and give them some support so they can get back to their baseline. Otherwise, they're just gonna keep declining until they die, okay? All right, so we're gonna cover this and then we will have a break. So, which patient on this screen is at the greatest risk for osteoporosis just based on the general appearance or general inspection? You don't know anything about their medical history. Which patient?
The thin one.
Everybody's like this, thin. Okay, Leona, tell me what else? She's thin, but what else increases the risk for osteoporosis?
Her age, she's older.
She's older,
We already said that, so.
There's one more.
Oh, cause she Caucasian?
Yeah, she's Caucasian, she's white. So Caucasian, elderly, thin. Just based on her general appearance, this is going to increase her risk for osteoporosis. So how do we promote her health to prevent osteoporosis? Not even. Regular exercise. What kind of exercise? Moderate to intense. Okay, so we're doing 75 minutes of high intensity workouts. Any special kind of workouts, Jansen?
She needs to lift weights.
Lift weights. Okay, what's your textbook say?
She said weight bearing.
Weight bearing exercises. Okay. Anything else we can do to help this lady promote her health to prevent osteoporosis, Patricia? I'm coming to you, Joseph.
Increase like her vitamin D.
You said increase her vitamin D?
Yeah,
Yeah.
calcium.
Vitamin D and calcium. Joseph, were you about to say that or something else?
Yeah, but I don't know what you said was smoking and alcohol use.
Okay, so don't smoke and then decrease your alcohol use if she had excessive use. Okay? Absolutely. Is that considered primary prevention or tertiary? Primary, because I didn't say she had osteoporosis. Okay, she doesn't. So if she doesn't have osteoporosis, and we know she has risk factors for it, such as her ethnicity, her age, and her frame, like her thin frame, then it becomes primary prevention. Okay, it's not tertiary unless she has osteoporosis. And if she had osteoporosis, guess what? We'd be telling her the same stuff. We're gonna say weight-bearing exercise. We're gonna say vitamin D, vitamin C. We're going to say no smoking, decrease your alcohol intake. It's still the same education. Does everybody understand why it's primary for one example and tertiary for the other? Yes? Okay. Now, which patient is at the greatest risk for osteoarthritis? Everybody do this? Oh yeah, this way. All right, tell me, what, based on what? Weight. So what impact does her weight have on her joints? Putting stress on the joints, absolutely, and that is what increases the risk for osteoarthritis in this patient. Nadia. It has a lot to, so Nadia's question, because I know they can't hear y'all with that. Nadia's question is if the risk for osteoporosis in this smaller woman is related to she's not having weight on the bones. So actually having weight, like more weight on the bones, is gonna increase the risk for osteoarthritis. What it has to do with is bone reabsorption and how it is delayed in people who don't have as much of that bone because they're so thin. It's a whole lot of pathophysiology into it. So what are we gonna do for the lady on your right to decrease the risk for osteoarthritis? She does not have osteoarthritis, but what can she do to prevent? Improve the diet, if she has a poor diet. What else? Exercise, yep. So I have patients who are morbidly obese, and I talk to them about exercise, and they're like, honey, I can't walk on the track. I can't walk at the gym. It's too much weight on my knees. My knees hurt. So what kind of exercises can they do? In the pool. The pool is the best exercise if your patient has access to a pool. Everybody doesn't have access to a pool. And so I recommend, what'd you say, Carnage? I recommend the YMCA. It's an income-based program. I love the YMCA. That's why I work out. Lots of boutique gyms around, but I prefer the YMCA because it's income-based. All right, so make sure you all know the difference between osteoporosis and osteoarthritis. Hopefully this image is stuck in your head, and it'll help you when you are interacting with patients and when you are taking your exam, okay? All right, before we get into the routine examination techniques, we're gonna take a 15-minute break. 15 minutes, so see y'all back at 11. We do have a quiz today, right?
No.
We'll get to it. 11 o'clock. Now, general health history, we talked about problem-based history, health promotion related to osteoporosis and osteoarthritis, and now we're moving into the physical exam. So history, physical exam, documentation. We're not really covering documentation because you all get practice with that when you all go to clinical. Okay, so this is what we're going to be talking about. So the next few slides will cover this. We'll talk about inspection, palpation, and then range of motion. So the assessment techniques, they don't change. It doesn't matter what the system is, it's just that GI, the order of them changes, but you're always going to inspect, and that's gonna be followed by some palpation or auscultation. So we're going to inspect the skeleton and the extremities for alignment and symmetry. So can somebody describe my extremities and my symmetry?
It's symmetrical.
So it's symmetrical, like my frame. Let me get the microphone. Okay, my frame is symmetrical. Yep, anything else about my extremities, my alignment, Ellie?
You're standing like erect, like you're standing upright, you're not like.
Hunched or leaning over, yep. So I have an upright and erect posture. Emily?
Your knees are in a straight line between your hips and your ankles.
Okay, my knees are in a straight line between my hips and my ankles. Anybody else? Free? My feet are flat and pointed forward. Tell me your name. Lindsay.
With symmetry, also I'm asking because I don't know for sure, but if you like the ability to move the same range of motion generally, or would that be more like?
No. Once we get to the range of motion section, you could say that the range of motion is symmetrical, but symmetry here is referring to, right, does one half look like the other half? Yeah. Yes, Kimberly?
Your spine has the expected curves.
My spine has the expected curvature. Absolutely. Spot on. Okay, what about my gait? What do you say about my gait? Smooth, regular, balance. What about my arm swing? I'm trying to be intentional about my arm swing. What did you say, Atticus?
Symmetry.
Symmetrical, you said symmetrical? Okay. Anything else? Nadia? Equal swing of my hand, my arms, and my legs. Say it again. No limping. All right. What kind of gait is this? Shuffle gait. What is this? Dragging. What is this?
Is that bowling?
Limping. Yes. Okay. So when you see somebody that has an abnormal gait, it's not just an abnormal gait. Why do we care about somebody's gait, Caitlin?
I wanted to ask you a question.
Okay.
When we're looking at your feet, are we also looking for the bobbins and the bears and then formation and supination of feet, or you just want us to be generic?
Just generic gait. Yes. Okay, what did I ask you? Or what did I ask y'all? Why do we care? Yes. You identify an abnormal gait. Why do you care?
Could be a pain.
Could be what?
They could be in pain.
Could be in pain, absolutely. What's your name? Melissa Pinmore. Okay.
It could be indications of like disease.
Yes, could be indication of disorder or disease, specifically musculoskeletal disorder, or it could be neurological disorder like Parkinson's. Patricia?
They could have problems with their joints or muscles.
Yep, and that kind of falls into what Melissa was just saying, problems with the joints and the muscles. Increasing the risk for falls, increasing the risk of injury, could increase could impact the activities of daily living, and we talked about the importance of being able to maintain ADL. So it's not just an abnormal gait, it's what impact does that gait have on their life, okay? All right, so I'm going to put you all in groups. Group work, everybody loves group work. Yes, you do. Yes, you do. So everybody's going to have a joint, and you all are going to send somebody up here to show us how we assess the joint for range of motion. Okay? So the first part is fairly simple. When you inspect my wrist, I'm just throwing wrist out there, what are you inspecting for? Deformities, what else?
Mobility.
Mobility, what else? What? What'd you say? Alignment, okay. What else? What about color of my wrist?
Edema?
Yes, edema of my wrist, absolutely. So inspection of joints is fairly simple. We're inspecting for color. We're inspecting for swelling. We're inspecting for deformities. Warmth, that's palpation. Yeah, 'cause you can't see one. We're in there though. So we're gonna inspect for those things, and then we're gonna palpate for things like warmth, tenderness, swelling, right? Yes, okay. So inspection and palpation, that doesn't change. We'll do the same thing for every single joint. It's the range of motion. Assess the joint for ROM, that stands for range of motion. Last night I started putting them in there, and I guess I forgot to take those two out, so just disregard that being up there. So you all are gonna have to know how to assess range of motion in practice. So you might have to say, my patient has limited flexion to their elbow, or my patient has limited adduction to their right hip. My patient has limited dorsiflexion of their foot. So you gotta know what that means. So, how many rows do we have? Well, how many of these? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so first row, y'all have TMJ. Everybody on this row has TMJ. The next row, Carlonisha, y'all have neck and the cervical spine. The row behind you has thorax. Who's on this row? Dalen, raise your hand high. Dalen's row has shoulders. Ellie, your row has elbows. Leona, your row has wrist. Don't tell me your name. What's your name? Takesha. Takesha's row, is that the same row that Rachel's on? Yeah, okay. Y'all have, where did I leave off? So y'all have hands. Leona, what do you have? Wrists? Okay, y'all have hands. Then Iman and Patricia, your row, y'all have hips. The row behind you has knees, and then the very last row with Lester and Priya and Micaiah and Tequila, Tremaya, y'all have ankles and feet. Y'all are not working together as a row. That's just what your row has. You're gonna work with whoever you wanna work with on your row, but I'm going to randomly select people to come up here and demonstrate the skill. So you gotta know what you're doing for your classmates, okay? All right, let's get to it. How much time y'all need? 5 minutes? Yes. 5 minutes.
Ooh, she gon'
Oh, it's okay. She can stand.
Today I'm going to check your range of motion, for your jaw. So if you could just look straight ahead. You could open your mouth.
Hey, Mary said, open your mouth and close it. Do it again, Kimberly. Open, close, okay?
And you could open your jaw, move it left out. If you could open, there you go.
Okay.
Okay, now you're gonna open your mouth again and protrude it,
Open your mouth again, protrude what?
for lower mandible.
Yep, so you gotta tell her that when the patient, you say protruding, they're gonna say what?
Stick out your mandible, or your jaw.
Yes. Stick out your jaw, and then back. Okay, that was good, Kimberly, good job, they're working that range of motion. Everybody open now, open, close. Side to side, open back up, side to side. And then protrude out, just like Ellie, they look like little pit bulldogs. Not pit bulldogs, bulldogs. Like Lester's bulldog. It's in a constant state of protrusion. I saw Lester's bulldog this weekend. His little teeth was just sticking straight out of his mouth. Or her, his little girl. Okay, so protrusion, retraction. All right, that's range of motion for TMJ. What's the one thing Mary missed? Something that she missed doing. Nadia, Atticus, what? Palpate. So you want to palpate the tip? Well, you want to palpate as they go through range of motion. Because what are you palpating for? Nodules, clicking, tenderness, right. That's about the only one where you need to palpate as you're going through range of motion. Yeah. Or crepitus, like that little Rice Krispie treat feeling. Yeah, that's what we're looking for with TMJ. Okay, next is the neck and cervical spine. Destiny's Child. Come on up here. Your patient is going to be Esther. Actually, y'all can do it from right there if everybody can see. Yes, correct. So Emily, are you Emily? Lindsay, I knew that was wrong. Lindsay said, when you're palpating the TMJ, the book says it's not considered abnormal if you hear the clicking or the popping unless there is pain. That is true. If you think about, what do we use the TMJ for throughout the day? What do you use those joints for? Talking and chewing. I talk all day, I eat all day. So my TMJ may have a little clicking and a little popping, and that's considered normal. So that is right. Because we're using that joint probably more than we're using any joint in our body, outside of our legs. Okay, cervical and neck.
So I'm gonna take the range of motion of the cervical spine. So if you will, doing flexion and extension, so if you will bring your chin down to your chin.
Good, what is that, Disney? That's flexion. Okay, keep it down, let's keep it down. Keep it down. Let's stop right there. A lot of people get this mixed up. Okay, Esther, go back down. Flexion, down, Esther. Flexion, okay. If you look straight up at Destiny, that is extension. Look at Destiny. That's extension. When she goes all the way back, what's that? Hyper extension. Yeah, a lot of people get that mixed up. It's not just you, it's okay. So flexion, extension, hyper extension. What's next, Destiny?
The lateral bending, so
Esther, let her tell you what to do. Take your left ear to your shoulder. I'm just repeating so everybody can hear, okay? Midline.
Bring it back midline and take your right ear to the center.
Don't move that shoulder, Esther. Don't cheat.
And
Okay. Mm-hmm. It's one more.
Rotation.
Rotation.
So you take your chin and move it towards your right shoulder,
Mm-hmm.
and bring it back midline, and take your chin and move it to your left shoulder.
Excellent.
Bring it back down.
Did you have any pain or tenderness, Esther? So Esther did not have any pain or tenderness with cervical range of motion, and her range of motion was full and intact. That's how you would verbalize that. That's how you would document that. Good job. Flexion, extension, hyperextension, rotation, lateral bending. No pain or tenderness, full range of motion is intact. All right, next up, cervical and thoracic spine. Melissa, Pinaflor, and your patient can be, who's this sitting next to you? Cynthia? Okay. Cynthia, I don't know. I know your last name. I do. Don't tell me I say it. Diochia. I know you told me. How do you say it? I was close. Diochoa. Diochoa. Okay.
Alright, so we're gonna do flexion, so stand up and then bend out the waist, so you want it to touch the ground.
Okay.
So I would also note the distance of the fingertips to the floor, if you get up, please. Okay.
So what is that when she got up? Extension. Yes.
And then
Just like the neck.
Right, and then
Yes.
hyper extension, lean back please from your waist, okay?
And I'm glad you tipped back like that, because most patients, especially once we get up to like 45 and up, particularly elderly patients, when they go back like that, they may tip back. And so you should offer some support. I know that's hard for y'all, but you would just stand next to her. Okay?
So sorry, the student nurse. Okay. Lateral flexions is great, and then I would stabilize the hips if needed.
Okay.
So you're gonna flex to the right laterally. Okay.
Uh-huh.
And I tap the left.
Now that's also termed lateral bending, just like with the neck. Mm-hmm.
Okay, and then rotation, so I can stabilize your pelvis. And
If
then
needed. You got that part.
Rotate to the right and rotate to the left.
Perfect. Any pain or tenderness? Nope. Full range of motion to the what? Thoracic and lumbar spine?
Yes.
Yes, that's right. Because the head was the cervical spine, and then all of this is the rest. If you remember from A&P, you had cervical spine, thoracic, lumbar. So we were just testing thoracic and lumbar. Everybody saw it? Flexion, extension, hyperextension, bending, and rotation. Full range of motion to the spine. Next is the shoulders. This is my favorite one. Everybody hates it. Colby, not Cody. Colby. You're going to assess Millicent. Shoulders, stand up, Millicent. And Colby is going, I have to do that, Colby. Or I'm gonna say Cody. Colby.
First thing you're gonna do is test flexion and extension, so take your arms and go forward as high as you can, all the way up to your ears, keep going, all the way. There you go. Do you have any pain or tenderness that way? So that's flexion, go all the way back as far as you can with your shoulders that way. You're good. Do you have any pain or tenderness that way? So you can put your
And what was that?
So that was hyperextension.
Hyperextension, so it's extension.
So extension is just behind right here.
Okay.
Hyperextension is past your torso.
So let's go back, start with flexion.
So flexion, move your arm forward,
Now go to extension,
midline.
and then hyperextension. Perfect, okay.
So adduction and abduction, you take your arms laterally the same way. So just take your arm, go as far out you can this way, go all the way up. You have any pain or tenderness on both sides? Try to hit it, just don't smack her in the face. And then this one's a little weird. It tells you like swing your arms back and forth in front of you. I don't really get that one. But
Now what was that you just tested?
so that was still abduction, wasn't it?
ABD?
No, yeah, that's ab.
Okay,
Yeah, ad is coming back.
yes.
So, and then there's something else about swinging your arm kind of like that for that. I don't really get that one.
So there are multiple ways you can assess shoulder abduction, like your abs, and that's what I'm gonna say to help y'all like differentiate between the two. And when I say add, like subtract, I'm talking about ADD. ABD, add like subtract ABD like your abs on your belly, okay? So flexion, so flexion, extension, hyperextension. What you just did for abduction, ABD like on your belly, you did this, right? Some people will do like a football pose, it's the same thing. So abduction like your abs is up here. What your book was saying for adduction, like subtraction, is coming towards your midline, so just coming across like this. That would be adduction, like swinging. So you were doing this, swinging across, so just this way. Okay, got it? All right, what's next?
External rotation, so take the palm of your hand and put it on the back of your head.
Perfect.
That's even on both ways.
Turn around, Millicent, so everybody can see it. Yep, all the way, there you go.
Basically make a T.
Okay.
You drop your arms. Now take one hand and put it in the small of your back. You don't have to keep your hands up on both of them. So drop both your hands. Now take one
It's how
hand.
your patient's going to be. Yeah.
Take one hand, put it in the small of your back. Your back, not your head.
Okay.
There you go.
You know what, you might need to say it from her.
I can't, that would be a bad example.
Oh, you can't do it?
No, I can't. So take your, alright, so that one, and now try to move your arm inward, right?
Oh, actually, that's fine, as long as you can get to the small thing.
Now you do the other one. So you don't have to keep the hand in your head.
Got it, okay. So let's go through that together, thanks, Millicent. We have flexion, extension, hyperextension. We have ABD, like your abdomen, abduction. We have adduction, like add and subtract across the body. A lot of people get external and internal rotation mixed up. If you think head to toe, E comes before I, external rotation, internal rotation. Got it? External rotation, the E comes before the I. We're working our way down, alphabetical order, external rotation, internal rotation. Any pain or tenderness, Millicent? Nope. Full range of motion to the shoulders. All right, David. Okay, your patient is Nathan, and you are doing, oh, I can't see it. What did y'all have? Elbows, okay.
Yeah, so first thing I would do is just palpate for like edema, temperature, or nodules. Next thing I would do is do flexion, so just move your arms this way, extension. And you want the full range of motion to be 160 degrees.
Okay.
And then you want your elbows at 90 degrees. And then that's supination, and that's crochet, and that's 90 degrees.
Thank you. And y'all don't have to know the degrees for your test. Okay? No degrees, thank you, but you don't have to know them. Okay? Flexion of the elbow, extension of the elbow, supination, like you're holding a bowl of soup. Projection. I know that kind of feels like the wrist, but it's not, it's the elbow. Flexion, extension, supination, projection. Full range of motion. Did you have any pain, Nathan?
I do not.
All right, no pain or tenderness to the elbows. Full range of motion to the elbows. Who's next? Tyler, Leona, Joseph. Joseph, you don't want me to call you?
No, it's okay.
Okay, Joseph, your patient can be anyone on your row.
Oh, yeah, okay.
Okay, now you'll have to stand up so everybody can, y'all might need to go over there. Like, get to the very end. So y'all had, oh, I see what happened. Y'all had the wrist, okay. Really good. What man?
This is flexion.
Okay.
And then you can do
What's that?
extension.
Nope. Close.
Extension.
Okay. And then what, Joseph?
And then, oh,
Joseph, think about your neck. So we had flexion, extension, and then what was that?
Oh, hyperextension.
Yes. Okay, let's do the same thing with the wrist. Flexion.
Extension, hyperextension.
Oh, that's not it. It's more.
Radial and ulnar deviation.
Okay, well, let's make sure everybody understands what that is. So where's the radial part? Where's the thumb? So how do we move our fingers if we're doing radial deviation? Does it make sense? How do we move it? In. Who's this knee? You got it right. She's like, in. Aren't you the person that plays volley? No, some sport?
That's her.
Oh, that was you. Oh, okay. I thought where the N was coming from. Okay. Was it basketball or volleyball? Basketball. When? Okay, so. All right, so your book says for radial deviation, you're going where? In. Y'all shouldn't forget that. Think in radial deviation. And then ulnar deviation, the ulnar is on pinky, right? And it goes out. It doesn't make sense when you say deviate, you would think it goes the opposite way. So really pay attention to that example. Show us again, Joseph.
Radial
Uh-huh.
and then ulnar.
Ulnar. Okay, so let's do it all together, everybody. Flexion, extension, hyperextension. Radial deviation.
Out.
In, Jasmine.
You just said some go in, the thumb go in.
Radial goes in.
Ah,
Yeah.
okay.
Ulnar goes
Out, owner go out.
Oh, for now.
Your owner, so do you? Huh?
We have the old so.
Are we good on that? Okay,
No, she has no hair.
okay, 4 rounds of
Like, wrap this up, because we're going to be like taking up this.
That's fine.
No, the hell?
Just give us a hand. You've been great to
Okay, period. I guess. All she can say is, that's okay. Okay. You tell me you know better than I do.
Miss Monica, you can feel the rest of the She gonna know after she takes the test.
Okay, we're gonna do the hips.
She has separated these.
Yes, move that hips right behind y'all. Right? Hand open that hand.
They had,
No.
Nobody had hands?
I will take classes in this.
Oh, the same group that had wrist had hands?
no,
Oh,
they
okay,
got
hands. Caitlin, you're assessing Gabby's hands. Oh, you have hands?
this
Oh, I'm sorry. Danita. You're assessing, don't tell me your name. What's it start with? Deanna? Okay, Deanna Shields. All right. So you're assessing her hands. Let me make sure I have the hands pulled up. Okay, perfect.
Okay, so I'm gonna palpate for any nodules, pain, tenderness in the joint. No pain, no tenderness. And then we're going to do the, well, they use the regular.
Yep, they
Can I
did
do
the.
the radio with the fingers?
Okay. That was the wrist. You're focusing on more of the hands and fingers.
Okay, so we're gonna do the finger abduction,
ABD.
ABD, ab, away.
Okay, away. So this is abduction. Okay.
And then we're gonna do, inflection.
Nope.
Finger-
What's the opposite of abduction?
Adduction.
Bring them
ADD.
together. Add, ADD, bring together. So that's why this makes sense for adduction of the shoulders. We're bringing together toward the midline. Adduction of the shoulders, adduction of the fingers. We're bringing them together. 1 + 1, adduction. Add like multiply. All right. ABD, as in your belly. Adduction, bring them together. Okay? What's next?
Finger flexion, you're going to make a fist for it.
That's it. Flexion.
Oh.
The opposite?
Extension.
Yes. That's it. You got it.
But, yeah, the finger, they had,
Yeah, that's
the
this.
finger extension was the thumb to the
Yes.
little finger.
Mm-hmm. So what is that?
Range of motion is intact, that's the finger extension.
Do you do all of them?
No,
Or
you
just
do the thumb to the little finger.
Okay.
The base of the little finger.
So your textbook says touch the thumb to the tip of each finger. See that? And then if you move the thumb away, that demonstrates extension. So this would be flexion, each finger, and then extension. Extension. Flexion, extension. Let's do it all together, okay? We just did the wrist, this is the fingers. A, B, D. B is in boy, abduction. How do we add? Bring them to. Adduction. How do we flex the fingers in the hands?
Fist.
How do we extend? Got it. Okay. That's the hand. If we're focusing on the finger flexion and extension, we're here. That's the thumb to each finger. That's flexion, thumb to each finger. Extension of the thumb is going to be the thumb away from the hands. Does that make sense, y'all? Because we're testing hands and fingers at the same time. All right.
This is away from the hand, or this is?
That is away from the hand.
Okay.
Yeah.
This would be still flexion.
Correct. I'm going to the fingers. The extension is when that thumb goes away.
Okay.
All right. Next group has hips.
It's our row.
It's your row. Okay. Rachel.
No. Our row.
Oh, I thought
This
it was-
row.
Oh, you just had hands. Okay, who is that beside Jasmine?
This Jimmy.
Oh, that's Juma. Who else is on there? I need you to come up here. I can't see. I can't see the different row.
Amon, Hannah, Khalil. I think they got her name right here.
Where are you sitting?
I'm on
That's why you're confusing. You are standing on this row, but that is your row. Go to your seat. Then I wouldn't be confused.
I'm reading. I was on the hill.
Okay. I feel like, what is going on? All right. What's your name? Blue shirt. Blue top. Yep. Are you going to assess Khalil's hips? Yes? Okay, let's do it. So I will tell you for your exam, you only need to know flexion, extension, hyperextension, abduction, and adduction of the hips. You don't have to know internal and external rotation. Y'all ready?
You said that you only know flexion, extension.
For the hips, you don't need to know internal and external rotation. Everything else you're responsible for. Takesha, what's her name behind you? Taylor. Oh, Kayla Reese. Okay, Kayla, you ready? You are ready.
You gonna lay down?
Yep, right there on that table. That's why I chose y'all, because you had that space right there.
I got something. That's why we could do. We practiced it.
It's too late.
Oh, good.
Alright, so pull your knee up to your chest.
Very good. What is that? All the way to your chest, Khalil.
That's flexion.
Yes.
Alright,
What was that?
extension.
Yes. And what's hyperextension?
Oh, is that when you put his foot over here and?
Nope.
Oh.
You're gonna have to turn.
Nope.
You're gonna have to turn around. You're gonna have to flip over.
Lay on his belly.
You gotta flip over.
Lay on your belly.
Don't listen to your class.
Oh my God.
That's what the book says. Okay. All right, Khalil. Back on your back. Yeah, thank you. nurse for protecting Khalil. All right, knee to your chest is flexion, back out is extension, and then slide your body over, Khalil, that way. And then you would drop your leg off the side of this table. So it's a challenge if you could, because this. So you're gonna drop it back.
Oh, like, when your daddy does this one, since there's nothing right here.
Yes, let's do that. Flexion of your left. Okay, that's hyperextension of the hip. Do y'all see that? It just goes off the side of the table and swings back. So slide over. There you go. Slide back. There you go. Is that her hip? Yeah. So that is the flexion of the hip. Let's do that again. Flexion. Again. Flexion. Extension. Hyperextension. There you go. Now what else?
You say abduction.
Ab, ABD, like your abs, absolutely away from the midline, and then add, come across the midline. So that was add, yes, like that. That's adduction. Does everybody see that? So we would do the same thing on the right side. We just can't show you hyperextension because of these chairs right here. Okay? Leon? Yes. We're gonna test the right leg too. We're gonna test the right because we're testing the hip. We're looking at the left hip. Yes, this is the left hip.
So it's abduction.
Ab, ABD, add across the middle. Leon? Good question. The question is, when you are assessing range of motion, are you supposed to be moving their foot or ankle? It depends. If you help them, then it's considered passive range of motion. If they do it themselves, it's considered active range of motion. So some of your patients will not be able to do it themselves. Let's say they just had a hip replacement and you're testing the range of motion, then you're assisting them through the ranges of motion. You would say it's intact, but it's passive range of motion that's intact. Yeah.
So like, would that be like a nursing intervention when you're, like if your patient has a hip replacement?
It could if you're trying
to passively range of motion.
Right, if you're trying to make the joint more mobile. Yes. Okay, we got the hips. Iman?
So leg extension isn't upwards, it's this way?
Say that again.
Is leg extension not upwards 90 degrees? Or is it like?
Well, it depends on how you're laying. So if you're on your back, if you think about, you said extension?
Yeah, because in the book, it's like when the person's like laying down.
Are they laying on their stomach?
No, they're back. It's like upwards, but is it this way or is it like the leg?
It's the opposite. Flexion.
Nah, the book shows something else.
Yeah.
Oh, okay, so you have more options in your book.
Yeah.
Oh, yeah, well, you can definitely use whatever option is in your book. I just went with the option I'm more familiar with.
Okay.
So if it says you can go up, sure. But I would go with, I'm gonna test you on what I just showed you.
Yeah.
So this is flexion, extension is out, complete opposite of that motion.
Okay.
Hyperextension all the time. Okay, next row. Knees. Y'all have knees?
Yeah.
Jalea? Jalea and Monica? Monica, would you like to be the patient or the nurse?
I can be the nurse.
Okay, I love it, Monica. Jalea,
Well,
you
don't
escaped
let
that
me
one. You did, you got out.
I already knew you was gonna call me.
We were
Okay,
just-
Monica, let's go ahead and assess Jalea's knees.
Okay.
Jalea, stand up
She
against
got
the
me
wall,
and me.
so everybody can see. Right,
No, ma'am.
So when assessing, the knees, first I'll inspect for alignment and symmetry.
Okay.
And, well, she has the tapered pants, so I won't ask her to pull up her leg up. So her knees are, aligned with her ankle
Okay,
and tibia.
okay,
Let's see, and they are symmetrical.
okay, let's do range of motion.
Okay, so range of motion, currently she's in flexion.
No.
She's not. No, she's not, she's extended.
Okay.
Extension. Flexion, she's going to, flex her leg backwards, 90
Okay.
degrees, and then I'll also ask her to see how far she can pick it up to the 130 angle.
Don't worry about
That's
the
not,
degrees.
okay.
Don't worry about that.
Okay, so flexion is backwards 90 degrees and hyperflexion is forward 15 degrees.
Hyperextension.
Hyperextension.
So everybody see, let me come down here. That's right, Mom. Flexion is here, right? Oh, go back, 'cause y'all aren't done. Flexion, extension, where's hyperextension?
Hyperextension, front 15 degrees.
Flexion, extension, hyperextension. Got it? Flexion, extension, hyperextension. Okay.
Okay.
Anything else with the knees?
We are to palpate.
Anything else for range of motion?
Oh, no.
Nope. Okay. Wonderful.
Okay.
You are done. Remember, I do advanced health assessments, a lot more with the knees.
Okay.
Internal rotation, external rotation,
Yeah.
as a, yeah. Okay, ankles and feet. Last group. Priya. And Priya, what you can do is come all the way down here by yourself, and you can demonstrate these ranges of motion on yourself. Can everybody see Priya's feet? No. Back. What about now?
Yes.
Okay, show us. I hope you're looking at the same picture I'm looking at. Are you looking at this?
Yeah, I have it written down.
Oh, okay, okay.
So for the ankle, you should be able to dorsiflex, so it should be go towards your face.
Okay. That's dorsiflexion.
And then plantar flex is when your toes are just towards the floor.
Well, actually, this is dorsiflexion. Where's the plantar flexion? Yes.
Towards the floor.
Okay. Dorsiflexion, plantar flexion.
And then, for the foot, we should be able to invert the foot, so it should be able to rotate outwards. And then we should be able to invert, so we should be able to inwards. And then we should be able to abduct the foot, so we should be able to turn away from the midline.
Yep, like that. Because otherwise it's hard to differentiate things.
Okay, and then abduct towards.
That goes wrong.
Oh, okay, towards the midline. And then we should be able to flex and extend.
Flex.
And then extend.
Is that
And then, an abduct and
You tell me? Spread your toes apart, and then back in like the fingers.
Oh, okay.
Abduction, abduction. Did you have a question on you? Let's do it again.
I'm trying to remember. Wait. Abduction is out, abduction is in.
There are a lot of different options. So there may not be a one size fits all.
Okay.
So let's have Priya go through it again. Okay, Priya, tell me what to do. Yep.
Dorsiflex,
Dorsiflex,
and then plantar flex,
plantar flex,
invert your foot,
then what to do?
rotate outwards, and then we're gonna invert,
Invert.
rotate, and then abduct.
That's ab and a.
So abduct, that should be abduct, and then adduct.
That's add for the.
Yeah.
Ab,
Ab is the leg.
Evert, invert. Got it? No, okay. No, they're not, because the way you hold your foot is different for eversion, invert versus abduction. Look at the image on.
I was laying here, then I flipped over, and I stood.
I'm so sick of you.
1437. I see what you're saying, Nadia. Nadia, I see what you're saying. It's the opposite. That's what Nadia is saying. Okay, let me make sure I'm showing y'all. This is why I wouldn't have this picture. Let me show you this picture.
I see, man.
You see? Okay, go right there. Tell me what this is. Flexion, dorsiflexion, y'all see? Can you scoot back a little bit? Dorsiflexion,
And then
plantar flexion, okay?
Okay, pointed toes.
What's next?
Oh, eversion.
What am I doing? Eversion.
Yeah, you're rotating outward.
What am I doing with my foot? Pinky. Am I doing this or am I doing this? Pinky.
Oh, you're like this. Toes keep coming. Yeah.
What is it? What is it, Priya? Okay, Priya, you go to the center of the class. Let me tell everybody what to do. Okay, so we're gonna get together. Let me actually show y'all what's on my screen to make sure we're all looking at the same thing. Oops. Okay, is everybody looking at this image? Okay, dorsiflex your foot, Priya. So straight up, plantar flex, go down. Now put your foot flat on the floor. No. Oh, okay. Eversion. You're going to rotate your toes up, like your outer toes. Pinky toes, like this, this. You got it? Eversion. That's eversion. Inversion is complete opposite. We roll onto the baby toe. Does that make sense?
What? No.
So the big toe goes up. So with eversion, the baby toe is up in the air.
Can you back up a little bit, Dr. Wallace, so I can see your toes? What?
Just like up here. On this.
The picture don't help.
Baby.
Okay, with eversion, with the E, the big toe is on the floor. The big toe is on the floor with eversion. In the image, the reason that it's showing you that little arrow with inversion is because it's trying to tell you to go the opposite way. So with inversion, you flicky flicky. So eversion, big toe is on the floor. Inversion, little toe is on the floor. Does that make sense? Eversion, big toe is on the floor. Let's stay here. Eversion, big toe is on the floor. Inversion, little toe is on the floor. Does that make sense? Just eversion, inversion. Hold on, Tyler. Next is adduction and abduction. Add is always to the body, so the foot is on the floor. Adduction, abduction. Add toward the body like multiplication, subtraction, ADD. Abduction away. Look at my hand is my foot. Dorsiflexion, plantar flexion. Eversion, my big toe is on the floor. Inversion, my little toe is on the floor. Adduction toward the body like subtraction, multiplication, here. Abduction, ABD, away. Okay? If it's confusing to you, it's because it's confusing. It is. And that's why I want y'all to use this when you're preparing for your exam. This image, because this image explains everything that I just said. When do you do this? Good question. So if you're working on an orthopedic floor, orthopedic unit, you're going to be doing a lot of this. You might not do it if you're working in med-surg, let's say, like I worked in surgical oncology. I never did this. But as a nurse practitioner, when people come in with joint injuries, then I'm saying you have limited range of motion to this. Limited range of motion to eversion of your right foot. If they have an issue, yes. Correct. It's 11:56. We have 4 minutes. Thank you. This is the image that y'all are using, okay? Are we on the same page? We're good. Yes. Yeah. You have to know all of these. The only range of motions you don't need to know for the test are internal and external rotation of the hip. Okay? All right, let me go back to my slides, because we have 7 minutes, and we have to talk about this quiz. Oh, I'm sorry, 3 minutes, it's 11:57. I'm sorry.
How about we try again next week? Right.
Okay, we'll sit through this part. So you're going to be assessing muscle strength of all of these muscles listed here on the slide, and your book gives you a really good way or some options to assess muscle strength, because there isn't one way to assess muscle strength. I'll show you an example. Emily. Okay, Emily, stand right here so everybody can see. Emily, hold your arms up like this. I'm going to actually sit. I'll probably push you down. Because I'm so strong. Okay, arms up like this. I'm going to push toward, don't let me push, okay? Excellent. I'm going to pull, don't let me. So I'm assessing her muscle strength or upper extremities. Another way I can do that, Emily, hold your arms out like this. Don't let me pull, don't let me push down. You okay? Oh. Don't let me push down. Okay, don't let me push up. So I just assessed muscle strength 2 different ways for upper extremities. Okay, there are a bunch of different ways. You can assess muscle strength of the elbow. You can assess muscle strength of the wrist. I can say, push your hands out like this. Don't let me push. Good, don't let me pull. I assess muscle strength of her hands. Yes. No. You just need to know upper extremity, lower extremity, and you need to know how muscle strength is graded. So there is a table in your textbook that Molly brought to my attention. The information above table 14.1 says that you grade muscle strength 1 to 5, whereas the table says that you grade muscle strength 0 to 5. What is correct is table 14.1. 0 to 5. So what I just found here was muscle strength of 5 to her upper strength. That's normal. Okay? And I can do those same motions to your lower extremity. I'll say, bend your knees, don't let me push, don't let me push. Same thing. Okay? So what you see here on the slide is just showing that you can test all of these muscles. You can test the neck muscles. So I'll put my hand on the side of your face, and I would say, don't let me push your side of your face. Don't let me push the other side. Then I'm assessing your neck. If I put my hands here, raise your shoulders, don't let me push that. Now I'm assessing her trapezius muscle. So you just work your way down on muscle strength. What's a normal muscle strength? 5 out of 5. Okay. How many minutes do I have here? 1. That's all I need. Okay. Make sure that y'all know the difference between muscle tone and muscle strength. What patient population may have poor muscle tone and strength?
Old people and cheering.
Older adults, yep. Who else?
Cheering.
No. Kids don't have poor muscle tone or poor muscle strength.
Oh, what is it?
Joy? Maybe somebody that has some paralysis. They're going to have very low muscle tone, and they may not have any muscle strength at all. Okay? So make sure y'all know the difference between those terms. The slides that y'all have for pediatric considerations and scoliosis, everything you need to know is on these slides. We don't have to go into any great detail for this content. And then this is for the older adults. Muscle mass may be decreased, and your patients may have decreased range of motion related to osteoarthritis. But unsteady balance, unsteady gait, those are never considered normal findings. Last slide is about lab this week. We are not on campus this week. You do not have a Go React video due this week. Yeah, you do. But you would know that if you read the course schedule. Okay. So, if y'all knew that already, you've read the course schedule. You have a comprehensive health history that is due November 12th. If you don't know what that is, it is in the lab information under the lab assignment folder in this module. I'm not in this module, in the lab assignment folder in black. Some of you are doing this assignment in clinical, some of you are doing this assignment on a friend or family member over the age of 50. Some of you have to record your encounter. All of that information is in Blackboard, and it is up to you to read it and figure out, who am I doing this on? Ethics.
So I did look at Blackboard.
Say that again?
I did look at Blackboard, I was just wondering though, for the ones in the clinical, do we need to like have them sign anything? Like,
You have to do
outpatient, like in clinical, for when we do like.
Ethics, you might have to come down, because I can't really hear you. Open that microphone. So if y'all have any individual questions, please come down after class, because everybody else is ready to go, as you should be, because it's after 12 o'clock. So if you have questions, Tyler, I know you had a question, come down here and ask me.
What about
I think Ellie had a question. Did you have a question? Well, it's somebody over here. So if you have questions, come down here and ask.
I don't have to take it.